introduced already, my name is Bob Handley, and I didn't know precisely what the audience was going to be, which was, as I gathered when I went to trauma care last year, which makes it much more fun to talk about. But just to say that I'm based in England, and so my view on this comes through English eyes. So who am I and what have I done? This is me. I'm currently a trauma and orthopaedic surgeon in Oxford, and I've been here as a consultant for over 30 years now. And I'm also the national clinical lead for the GIRFT Adult Orthopaedic Trauma Program. Now, GIRFT stands for Getting It Right First Time, and it's a program that started out in elective orthopedics about 10 years ago, looking at unwarranted variation, that time around joint replacements and the like. And now it's spread to all the specialities within England, not just surgical, but medical, and going out into primary care as well. But it's the same basic theme, looking in different trusts around the country to see how things are done and how they match up to the national data and the like. So I've now been around about 150 trusts, mainly in Zoom calls, just a couple of face-to-face. But so I've got a reasonable eye on what's going on around the country. And previously, I was relevant to tonight. I was a member of the NICE Guideline Development Group for hip fractures. So NICE, the National Institute of Care Excellence, did a hip fracture guideline. We started reporting in 2009, and you can see I've done a few other things there, all related to trauma. So just cast your mind back a little bit. So this is me a long time ago. Before I started training in orthopedics, I spent some time in the Antarctic, and then when I came back, I started as a junior doctor, and ever since that time, there's a theme that was evident. So this is 1980, so this is 44 years ago. It was clear that with hip fractures, we knew full well that there were things that were not right, and that was all the way through my training. We knew that surgery was carried out by unsupported juniors. Medical comorbidities were managed by surgical juniors and not by physicians by and large. There were delays and repeated periods of starvation to hip fracture patients because the cases were often done out of hours because there weren't trauma lists during the day. There was a belief that prevention was anybody's job but mine, and the patients were in effect second-class citizens. And that I think was a general perception. Now, those bullet points I wrote in a blog for Quality Watch 12 years ago, and that was a reflection on what had led to a really quite a significant change in practice. So a lot of people knew there was a problem, and there was a change that occurred in the way in which we looked after hip fractures. And it's quite interesting to try and understand why and how we actually managed to get the change, not just in theory, but in practice. So you can see what I've drawn there is like a feedback cycle. And so the clinicians all knew there was a problem. So the clinicians sitting at the top, they knew they weren't doing a good job. They often would shelve it to somebody else, but in their hearts, they knew that there was an issue. There were lots and lots of hip fractures. So sitting over here, there was lots to deal with. The clinicians knew we weren't doing it well, but were managers on the same side? Not necessarily. But the National Hip Fracture Database, NHFD, started as a voluntary collection of data, and then because there's so much data that can be collected in that way, it became very clear very, very quickly that there was a lot of variation and things weren't being done very well. And then there was a change which sort of oiled that wheel. There was BPT, which stands for Best Practice Tariff. And Best Practice Tariff meant that there was some money that was attached to doing things, to fulfilling certain criteria. And they were really quite straightforward. You had to be seen by an orthogeriatrician. You needed to have your operation within a certain period of time. You needed to be mobilized and seen by physiotherapy. So there were 6 things that were there. And if you fulfilled all of those, there was money attached to the care of that patient. And that gave this sort of virtuous circle of a positive feedback situation. And if you remember from O-level biology, then Positive feedback can lead to a change of state. So things like the clotting cascade is positive feedback. So you go from liquid blood to solid blood. And so change of state, whereas most of the feedback systems we have in our practice are negative ones, which tend to maintain a steady state and don't actually allow for change. So this was the change that occurred, and this really occurred in the 2000s. And there was significant changes in morbidity and mortality, and hence what I wrote in that blog in 2013. And so the NHFD provides wonderful data. Those of you who have not looked at it, if you just type in the initials NHFD into one of the search engines, you'll go straight to their website and you can look at this data. You don't need a password. And this is, as you can see, this is if I look at this to the end of January 2025. So that's the previous year's annualized data on just under 71,000 hip fracture cases in England. And it will show you admission to the right ward, prompt surgery, prompt orthogeriatric review and the like. So those figures are right in your face and they're very easy for everyone to see. So let's just look at some of the things that were said about how you should manage a hip fracture patient. So this is from the NICE hip fracture guidelines that came out in 2010. And I'll highlight a couple of areas in there and just let you reflect on how we apply them to hip fractures. So orthogeriatric assessment is a fundamental component of looking after hip fracture patients, and most people would accept that. Interestingly, though, if you go back to that chart, so if we look at this, so prompt orthogeriatric review looks pretty good. So nationally, these are the national figures. These aren't individual hospital, which is why the overall and that large print one agree because they're the same. So 88% have prompt orthogeriatric review, whereas only 58% have prompt surgery. So that implies that surgery, well, that's a bit lackadaisical. There are any, but if you look at what the targets are, the prompt surgery is at within 36 hours of arrival in ED, whereas a prompt orthogeriatric review is 72 hours, which seems a little bit odd that you don't need to be seen by an orthogeriatrician until to hit the target until a day and a half after you've had your surgery. And that was because when the targets were written in 15 years ago, there were very few orthogeriatricians, and it was pragmatic. You had to account for the weekend, but it's not followed on. So interestingly, even for hip fractures, the orthogeriatric cover isn't all that you would anticipate. And so weekends and are not covered in most places. Or you can look at this one. So it says early identification of individual goals for multidisciplinary rehabilitation with the aim of recovering mobility and independence. So this is early identification. So when I've been going around, you ask, when does an occupational therapist first meet a patient admitted to an admitted orthopaedic trauma patient? And you could ask that same question for orthogeriatrician, pain team, nurse familiar with MSK trauma, anaesthetist, dietitian, or surgeon. When do they first come in contact? But with reference to that early identification of individual goals, the OT is often quite important because they're looking at what the person can achieve when they go out. And it's quite interesting in that as soon as you're identified as being admitted to hospital, you tend to bypass all the teams at the front door who may introduce you to OT and physio, go to the ward. And for quite a number of places, you don't meet OT until you're declared medically fit for discharge, which may be several days after your initial admission. So even the hip fractures are not getting the first class service that you would imagine that they should, because things are delayed. Once you admitted to hospital, you miss that thrust that there is at the front door to try and turn people around in ED. Look at the bottom bits: coordinated orthogeriatric multidisciplinary review, liaison, integration. It's all talking about teamwork and the like. And how well does that work? Well, we'll look at that in a little bit more detail. So I show this picture when I go around with my GIRFT reviews, and Some of you may recognize it, and I use it to emphasize the difference between strategy and tactics. So those are deck chairs, and you could spend the time rearranging those and getting things just right, but they're on the deck of the Titanic. And so it's probably better to look at the strategy and to look to see where you're going and the overall picture, not to focus too much on individual components. So when we're teaching junior surgeons about how they're going to approach a problem, one of the things that you emphasize is that first of all you have to decide where you're starting from. So you need to identify your starting point, and it's just like going out for a hike in the hills. You want to know where you're starting from and where you want to get to, and then you can plot a route to get between those two. And we're quite familiar with that concept within healthcare, so that there'll be umpteen pathways that you'll be familiar with to get you from one side of a problem to another. But the first step becomes disproportionately important, and the first step is not always as you would imagine. So let's just look at one aspect of how different people may be involved. So if we go back to this picture, the stepping stones are not lumps of rock, but they're individual people. So that may be ED, surgeon, anaesthetist, OT, physiotherapist, all the like. And you need all those people there to get them across their pathway. So one of the things that we looked at, this was just from the medical point of view. This wasn't looking at the allied health professionals. So we did a survey of just over 1,000 patients who were admitted under orthopaedic trauma across 27 hospitals, and to look to see what specialities were involved in their care. And unsurprisingly, you don't get 100% of everything because it's not documented, but ED, the emergency department for pretty much everyone, radiology for pretty much everyone, anaesthetics and orthogeriatrics for well over half. And then as you come further along, other physicians, only about a third, other surgical specialties really quite low. So this is this isn't just hip fractures, this is the generality of admitted orthopedic trauma patients. So our key partners would be ED, radiology, anaesthetics and orthogeriatrics. If you look to see who attended the deep dives when we did GIRFT visits, in the first 30 deep dives, the only group that were there all the time were trauma and orthopedic surgeons because it was labelled as their meeting. But orthogeriatricians less than half, anaesthetics less than half, because the ownership is not felt to be there. So you get this dilemma that we'll talk about later on of a named consultant from a single speciality, and then everybody else has more of a service level arrangement, and they don't have ownership within it. If you ask who attends your M&M meetings, and again, you can see that the big column is there for T&O, but then every other specialty is pretty low. Orthogeriatrics do well, they're over 50% here, but everything else is fairly low. So the meetings tend to be by single speciality rather than the team looking after the patient, which is perhaps a little odd. So when you go back to that and you think, where am I starting from? So where am I starting from? So what is the group that we should be bringing together when we're the group of patients that we're thinking about how we're going to manage them? So this is the front cover from the Journal of Trauma and Orthopaedics, which is the journal put out by the British Orthopaedic Association. And you can see there that the headline is "Don't let a fracture obscure the bigger picture." And there is a fracture. That's a hip fracture. As it happens, that's not actually a neck or femur fracture. That's a trochanteric fracture. And so the label NOF wouldn't apply to that. But the whole pathway tends to get labeled as NOF pathways by people. But the bigger picture is to think about the patients. And so similar patients rather than similar fracture patterns. As it happens, that's my mum and that's my dad. And I think it's more important to consider what their needs are rather than the anatomical location of the fracture. And if you go back to this pathway and think about how pathways operate within hospitals where you are, that first step becomes hugely important. Because if you look at things, it'll vary around the country. So hip fractures pretty much universally will be admitted under orthopaedics. That will be their first step on the pathway. But take a fracture which is only a few inches away from that, a pubic ramus fracture or pelvic ring fracture, that gets admitted under a wide variety of different people. So it can be orthopedics, but it can be general medicine, it can be orthogeriatrics, it can be that they'll stay down in ED pending mobilization. It's disparate, and so the rest of your needs on that pathway are all very similar. You need pain relief, you need mobilization, you need care of your comorbidities. All those are there, but you can't enter that pathway because, in effect, you don't have the right passport at the beginning if you don't have the hip fracture. And that is very, very common. So when you go around and ask in different hospitals, do you have multidisciplinary team meetings? Yes, we have it for hip fractures. Do you have it for other fractures? No. And so there's a discrimination. It's almost like an entry pass to the pathway, which is odd. And it's not what patients would imagine. And I think in reality, it's not what we feel is right for the patients. So not just NOFs, but NAFs. And the essence of that at the background is it treats similar patients similarly. So NAF is a term that we've used for non-ambulatory fragility fracture. So a hip fracture would fit into that group, but not all non-ambulatory fragility fractures are hip fractures. So we'll talk about it a little bit more. And we get into this, you see. So you get professionalism, so us using our clinical judgment on what we believe is right and proper versus bean counting. So the bean counting is to look at these numbers down here, to look at these targets, because they're the ones that are set for BPT and the focus gets on them. That's where management will push us to look at that, and almost to that other things get put into the background. So as professionals, we have a responsibility to treat people equitably. So what on earth is a NAF? What would I group as a NAF? Now, what we try to steer away from is giving it an anatomical definition, because by pointing at that picture of my mum and my dad and looking at them, what I was trying to emphasize is that there's a patient with a similar group of needs. So essentially it would be somebody who's had an injury, a musculoskeletal injury. And the common things with musculoskeletal injuries are you're going to need relief of pain and restoration of mobility. Those are the common things with musculoskeletal injuries, irrespective of age and nature of it. If you look at the group that we're talking about with the non-ambulatory fragility fractures, so the older patients, there are two other important things to put in there in terms of the management that we first think of that of trying to get them out of hospital again, which is management of their comorbidities, because the average age is going to be over 80 who's coming in with such injuries. And by far the commonest complication is delirium, so the avoidance of delirium. And the other thing which is often neglected is what I put at the bottom there is recognition of the need for end-of-life care. So if you look at well, we will use the figures for hip fractures because that's where we know it best. But the mortality for hip fractures, before the best practice tariff and the like came in, the bald figures were 10% at 30 days and 30% at a year. That was the mortality, which is higher than it is for a lot of cancers when they're first diagnosed. And so this was a group who may be in their terminal decline, and that needs to be recognized. So those are the patient's needs, and we should treat patients with those similar needs similarly, and we quite overtly don't. Now, are there a lot of NAFs? Is it a problem that's worth worrying about? So we put this to the data analyst that was working with us at GIRFT to try and just get a rough idea. And this is the figure that we came up with. If you put them all together, all the patients are admitted and are in hospital having hurt, broken something, they come to about 2.25 million bed days per year. 2.25 million bed days. This is in England, and that's about 7% of all the NHS beds. The only exclusions from that, if you look at the way in which NHS counts its beds, you get this. If you look at the legend at the top, there's general and acute beds, so the dark colour, which is this big block here. Then the others, the light mid blue and the lighter blue, are mental illness, learning disability, and maternity. So essentially, all the things that we would imagine in a hospital, apart from the mental illness, learning disability, and maternity, are general and acute beds. Now, these are figures from the King's Fund, and they had down here that in 1987 there were almost 300,000 beds, of which over 150,000 were general and acute. When you get to here, in 2019-20, it's come down to 100,000 beds. So beds are in short supply, and as I say, the amount we occupy is just under 7%. There's a hand up. Is there a question that somebody would like to ask? Ellen Tebed. If you're speaking, I can't hear, so I'll carry on. So that's the total number of beds, and it's a big proportion of that. And if you look at the proportion as it's anticipated it's going to happen over the next 30 years, the National Hip Fracture Database estimates that the number of hip fractures in England will double in the next 30 years. That's despite preventative measures. And if we are trying to trim the number of people that we admit into hospital, which is one of the government objectives, so more of the respiratory illness, which is the biggest group of emergency admissions to hospital, if more of those patients can be managed in virtual wards and hospitals at home and the like, but you're still going to need to admit people who have come in because they have broken something, then our proportion is going to go up, and it's going to be a bigger and bigger issue for the health service. So where should these patients be? So it's an interesting issue as to who should have responsibility, whereabouts in the hospital should they be. So if we break it down into a couple of blocks, now this is a made up graph: initial assessment and pain relief, the surgery and the immediate recovery, and then ward care, mobilisation of comorbidities, etc. And if you plot that out for an older patient who's come in with a fracture, now they don't all need an operation, but even if they do, the time that they should spend in ED should be, as you know, 4 hours. But if we give it a bit more, give it a half a day, then the time in theatre is going to be several hours. All the rest of their time, when they need ward care, mobilisation, comorbidities, and discharge planning, so the vast bulk of their time is nothing to do with ED or the surgery. And yet there's a persistence in cohorting patients by whether they need an operation or not in many hospitals. And you do cohort surgical patients, you cohort those in an operating theatre, but where they need to be with the right physiotherapists, OTs, and nursing staff is on the ward. And there's a difficulty about achieving that. So there was a recognition within the British Orthopaedic Association several years ago, and they produce these things called BOASTs. So this is a BOA standard, and the first BOAST was in about 2009, and that was for hip fractures. When that was revised, it was changed. The title was changed to the care of the older or frail orthopaedic trauma patient, on the basis that we should be caring for patients with similar problems in a similar way, and we didn't want to just highlight hip fractures. And so that was the BOAST in 2019 that came out. And last year we had the opportunity to bring out another pathway, and this time a pathway with a broader first stepping stone. So instead of it being hip fractures, it being a non-ambulatory fragility fracture pathway. And so if you go back to the BOA one, our logos at the top there are BOA, British Geriatric Society, NHFD, and this is the Fragility Fracture Network in the UK. When we did the one through GIRFT, it looks like we've won Crufts or some pony show. We've got logos from everywhere because everyone came on board, all the clinical groups, because it was an area where I think once they got involved, we could all see that there were things that needed to be improved. So physios, OTs, emergency medicine, and the like. And that's the front page of the fragility fracture pathway. So there is a sort of plumbing diagram if you turn it over. And the key component of the plumbing diagram is this bit here. And just to make it a bit bigger, it's that as soon as you're admitted and you come into that group of being a non-ambulatory fragility fracture, so you got the injury, you need your pain relief, you need to start to mobilize, whether that needs surgical adjuncts or whatever, but you need to be in an environment where you are under regular review by all the people who might be able to help you. So there should be multidisciplinary review that's continuing. What happens in a lot of places now is because you're segregated to go off to different wards under different people, then you get cut off from other folks. So if somebody's admitted to my ward under me, then their relationship to their medical ongoing care is quite different than if they'd been on a medical ward under a physician. And if they're on a medical ward under a physician, then they may well not have the right physios and OTs to get them mobilized. And if I've written something in the notes like non-weight bearing for 6 weeks, they take that as gospel truth and won't do it. Whereas if the patients were with us, the physios and OTs and the nursing staff would be on your case telling you that, no, this isn't right. To get this patient home, we're going to need to mobilize them. And the working together tends to progress things more rapidly. Now, there are difficulties in implementing pathways. Now, this is another example of a path. You can see there's a nice tarmac pathway, and you can also see that there's this thing here. Now, the Scandinavians have a term for this. They call it a desire path. And if you look it up, you can see that what they claim they've done at various times is if they want to put a path somewhere, they'll wait until the winter and see where the footprints in the snow go, and then they'll know that's the direction people want to go, and then they'll build the path in that direction. If you do what we did, this is my hospital, this is where I work, if you build the path that way, and actually everyone wants to go that way, then the hedge gets trampled down, so you put a better hedge in there and that gets trampled down, and people keep going the way that they want, because there's an inherent tendency to follow a particular path, and to change that, you either need to nudge them in the right direction, or you need to fully understand what it is that's motivating them. So there are a couple of things that we might be able to consider as being obstacles, and perhaps how we can try and overcome them. So I said about the named consultant and equitability. So what am I implying by the named consultant? So one of the general principles of being admitted to a hospital in the UK is that you're under the care of a named consultant. And now, those of you who work in acute hospitals will probably recognise that the named consultant, the one that appears on EPR or whatever your system is, often bears no relation to the people that are looking after the patient at the time. In our place, we've certainly had people who have retired a little while ago or have left to keep their names keep appearing. So the named consultant is in terms of day-to-day clinical management, is often not that important, but it has a real significance in the overall structure of the place, because you do carry that responsibility. And the named consultant nearly always comes from a single specialty. So if in your institution pubic ramus fractures are admitted under physicians, then all the people will be physicians. If it's something that comes in under orthopaedics, then they'll all be orthopaedics. And what that allows is the other consultants, the other teams, to step back, which is an odd situation. It's unusual for the group of people admitting patients to come from a mixture of different specialities. I mean, interestingly, talking to a trauma care audience, the one group where I'm familiar with that happening is some institutions with the major trauma, where the admitting team, the major trauma consultants, may be drawn from different specialities, but by and large, they come from one specialty. And the dilemma that causes is that if you then try and cohort patients to put all the non-ambulatory fragility fractures together, whoever the group of named consultants are fearful that they're going to be suddenly burdened with a much greater group with everybody else not supporting them. And so they put up they dig their heels in, because unless there's a route to getting collaboration, then it's very, very, very difficult to persuade colleagues that this is the right path to do. So there's that inherent reluctance to do it. You may recognize that in other areas in the way you practice as to who admits head injuries that aren't going to receive operations in any of your hospitals. That varies quite a lot around the country, and by and large, the consultants that are admitting them would rather they went under another service. And it's not a healthy attitude that there should be. The other thing is that I mentioned that best practice tariff was lubricated that positive feedback cycle for changing how hip fractures were there, and there's no money. So by and large, there's going to be no extra money for any changes that one might bring in now. In fact, you know that the budgets are so very, very tight. So one of the motivations you can bring about is equitability. That's it. So when I mentioned about professionalism versus bean counting, equitability is really something that comes to the professional. The professional should be providing equal care to people with similar needs. So you can ask those who are in a senior medical position in your trust, does the medical care I receive as a patient vary according to whether I have a fracture or not, the location of my fracture, which ward my bed is on, or the day of the week on which I'm admitted? And if you ask that of people in a trust as you go around, they know full well that it varies with each of those, because that's pretty much uniform in all trusts. And that's not what patients would expect. It's not professionally what we should be accepting. And so there is a pressure to be equitable in the way in which we manage patients because of our signing up to our professional background. In your trust, does the care to get me back on my feet vary with the location of my bed, the team of therapists who look after me, and the team of nurses that look after me? And if you, as I've been going around with GIRFT, I've asked the therapists and the nurses that are there, how much does it differ where my bed would be as to how I'm mobilised? And if you're on a medical ward, if you've been what people would term as a social admission with a proximal humeral fracture, or you've got a pubic ramus fracture, or you have a wedge compression vertebral fracture, and you're not on a ward where there are physios and OTs and nurses used to managing injury, then it's slower, because there's not surprisingly, there's a worry for people who aren't used to looking after fractures as to what they should be doing. They tend to be more protective of the patient because they're worried about doing harm. Whereas if you're in an environment where the importance of mobilization is evident, then you can be doing the patient good, perhaps by cajoling them into doing a little more than they would do elsewhere. So if you go back to the front page of that non-ambulatory fragility fracture guideline, so this is the bit I showed you earlier, and there's a bit in here talking about higher level governance. And if you explore that, to try and bring it together, what's been put there is that somebody on the trust board should have oversight of equitable care. So we should be able to go and ask somebody on the trust board those questions that I brought up on a couple of slides before. Would I, as a patient with similar needs, would I be being treated similarly if I didn't have a fracture or did have a fracture, or what that list that I went through? Because it needs to be somebody above the individual divisions in the hospital to bring those disparate groups together. So in a managerial sense, in the vast majority of places, the emergency department, the physicians, the anaesthetists and the surgeons are all in different divisions. They're in different managerial divisions, different governance structures. And so they don't have anything to bind them together until you get to the level of the trust board. And so although the trust board can't micromanage it, there should be somebody there who is at least providing the oversight to show that these things are being done. And then the argument that you get is that, well, we'd like to give everybody equal care or equitable care, but you know what we need is a further 3 orthogeriatricians, or we need more OTs, and the issue with that is that that's fine. There should be aspirations for bringing up the general care of everyone, but equitability isn't synonymous with increased resource. And so this was my first venture into AI. I asked one of the, I think it's ChatGPT, to help me draw a picture of a child with 2 biscuits and one with none. So if they were my kids or grandkids now, and their solution would be that I buy 2 more biscuits. Strangely enough, my solution is that the one with 2 gives 1 away. And equitability can mean using the resource that you have currently equitably, not just what is often a pie in the sky hope for increased resource, because as you know, by the time you put a business case together, submitted the business case, had it returned, had it reconsidered and then declined, several years can elapse. And so effectively you're pushing the problem into the long grass, whereas you do have an issue that you need to deal with now as to how do you treat the patients that are under your care at the moment in an equitable fashion. And I think that can provide the lubrication, as it were, to another positive feedback cycle. So there are a lot of hip fractures. There's even more NAFs. There's a huge number of NAFs, and they need similar things. They got the similar needs: pain relief, mobilization, and prevention of complications and treating comorbidities. By and large, the clinicians know that there's a problem. I mean, really, if you talk to them, and the AHPs, they know that there's differential treatment. I think sometimes the managers are unaware of it, and it needs to be pointed out to them. It needs to be pointed out that if you're treating the patients with similar needs differently, then probably we're not treating them as well. And if that means that there's an increased hospital stay for patients who are not being treated optimally to get their comorbidities and their mobility managed as well as possible, then that's consuming bed days. And a little bit of percentage change in bed days when we occupy such a large proportion of the hospital is important. And then down here, instead of NHFD, I'll put a NAF in the middle of it. And there is an aspiration at the moment with the National Hip Fracture Database Programme to collect data on more than just hip fractures. They already look at fractures affecting the rest of the femur, but probably the big next step would be to look at pelvic ring fractures in the older patients, because there are a lot of those and their treatment is very difficult. And there's something that's called the Hawthorne effect in research, that people tend to change their practice just if they know they're being looked at. Even if there's no carrot apart from the knowledge that you're going to be exposed, the differential treatment that would be exposed may in itself promote a change in practice. So I think that in essence what you're looking at is that you're starting off with a group of similar patients, and there are a very large number of similar patients with musculoskeletal injuries who require admission because their mobility has been impaired. And that doesn't necessarily restrict itself to lower limb fractures. As I mentioned, it's not to do with the anatomical location. So somebody with a proximal humeral fracture who doesn't who needs their arms to help mobilize is just as compromised as somebody with a lower limb fracture. And you're trying to get them across that chasm to achieve those end results, but avoiding the major complication of delirium. I think hopefully the pathway that we've developed will at least be a way in which it's been widely promoted already, and as we go around with further visits with GIRFT, we can look to see how places are paying attention to it and how they're beginning to accommodate the idea that you should be treating a larger group of patients. So I think the essence of what I've been trying to say is treat similar patients similarly and don't base it on anatomical location, base it on the needs. And the NAF patients have similar needs, and those needs being they need pain relief, restoration of mobility, management of comorbidities and avoidance of delirium. It is genuinely a big group of patients. And so it's something which is worth us as professionals saying that we should be treating them equitably, but it's also worth those who are in managerial positions listening, because it is such a high proportion of the hospitals in which they're helping run. Having the patients in the right place is key. So teams play better on their home ground. I mean, we know that from practically any sport you watch at. You play better at home. You play better if you've got colleagues around that you can talk to. You've got support when you get change in the team membership. So you get new people arrive, they can ask others, how do we normally do it? And it's important that the patients are cohorted by their overall needs, which are not whether they have an operation or not, but it's those other big needs of mobilisation and the pain relief and the like. Put the patient at the centre. So if you have genuine patient-centred care, it shouldn't be based on the name of the traditional specialty in which they've been admitted under. So if you put the patients at the centre, you naturally group those with similar needs, and you don't segregate those that are under the name of me as an orthopaedic surgeon or one of my medical colleagues, because they should be managing together. And those who are professionals, so those of us that belong to a professional organisation, should act professionally. Even if we've got managerial responsibilities and we have to balance how we apply our professionalism into the bigger picture of keeping the ship afloat and running the organisation, we should still be acting professionally. We can't push that aside. We tend to perform to target. So one of the arguments would be, yeah, talk about NAFs as a target, make it a bigger target, and that should hopefully be easier to hit. So not just NOFs, but NAFs. Treat similar patients similarly. In addition to the NAF pathway, the general report for adult orthopaedic trauma from GIRFT has now been published. Currently, it's available through the NHS Futures platform. It'll soon be accessible via a general search on Google or the like. But it's there, and it contains a lot of the basic concepts that we've had here. And one of the underlying principles is team management and not anatomical management. So my name's Bob, and together we can fix it. Thank you very much.
Oh, amazing! If you're going to finish a talk, finish it on a slide with Bob the Builder on it, and that's that. I love it, absolutely love it. Brilliant, thank you so much. So let me just find my keynotes as I always do this, and share the screen again, if it lets me, since technology is being as technology does for trauma care and failing us once again, which is perfect timing for the conference. And everyone can see that. Wonderful. So thank you very much, Bob. So I can see questions popped into the chat already. However, before we move on to the questions, and please do get questions in. I know it's a more intimate audience tonight, but what that means is we can give more time to your questions as well. So anything you want to ask at all, no questions too silly, no questions too difficult. Get your questions in and we can have a look at them together. However, because, you know, there is no rest for the wicked, this week we come back from conference is our next webinar. So if you want to learn all about the new MATS tool that's coming out, and this is looking at developing the national, the tool that's just about to be released. So this is sort of how it came into existence, and that's going to be presented by Josh Miller and Gordon Fuller on Thursday, March the 20th. So do scan the QR code that's on your screen now, if indeed I put the right QR code on there, because my brain's so webinar at the moment, so conference at the moment. So do scan the QR code that's on your screen now, and hopefully we will see you in 2 weeks' time. Do not scan this QR code. No matter what you do, nobody scan this QR code. You are all getting a free CPD certificate for joining us tonight. I know I normally put the rule in of members, non-members, but because it's a more intimate audience tonight, because it's CPD week, why not? Everyone, don't scan the QR code. Step away from your phones. You will all receive a free CPD certificate tomorrow. So now it's time for the Q&As.
So I can see one that's there. That the one it reads, from a pre-hospital context, is there anything we can do to help this pathway run smoother? I'll say something about that bit before I read the rest of the question. So one of the interesting things that came up in relation to pre-hospital care was brought up by an orthopod from elsewhere, was that when do the timings start from? So the timings start from an easy point of of collating the data. And so it's from booking into the emergency department, because that's a time that's readily available. And when this was set up, so when BPT first came about, is over 10 years ago, the idea that you might be sat in an ambulance for I don't know, a variable length of time, let's say, outside of a hospital, just wasn't there. And so that wasn't considered. And so one of the things about pre-hospital that somebody out there may be able to answer is how readily available in pre-hospital data, and for us to look at, would be the time of the initial call, because that may be a better starting point than the time that they're booked into the department, because some places it's so I went and collected somebody who I'd been told had a hip fracture, who the ambulance service hadn't got to by 7 hours. I went and picked them up in my car and took them into hospital, because otherwise this poor lady in her 80s was sat there. And I know that's happened elsewhere, and then you can be in a queue outside. So one of the things about pre-hospital is how accessible would be generally the time at which the call went. But then the second part of the question, was there things that you could do to make the pathway run smoother? Detailed documentation of baseline mobility, frailty score, tolerance of analgesia. I think that so I think that having that information available probably doesn't change what happens immediately on arrival in ED. But one of the areas when it does is when you first make your assessments of what you think the targets should be for that patient. So you remember that picture I put of where are we starting from and where do we want to get to? Well, as an orthopod, what I see where we're starting from is a broken leg. Whereas what you're suggesting in that question is I might be seeing that a lot of other things, if only I'd asked about them or knew about them, and that will temper as to where you think you can be getting to, and I think that is where hopefully in the future, if we have earlier involvement of people who know the pathway, because I didn't highlight it on there, but the idea is a single point of contact from somebody who understands the pathway, and then you can start to get people involved at the beginning who can take into account baseline mobility and frailty score to see what should you be reasonably trying to do. Surgically, for hip fractures, it's quite straightforward. We're pretty much universal as surgeons, happy to write down fully weight bear from day one post-op. For practically any other operation, that's not the case. And there's been surveys done by juniors to see what we as consultants write in the notes. And we don't write what we say we will write when we're at meetings, because we say we'll let people weight bear, but then everyone's a special case. And so it's so having that data readily available at the beginning, I think would help. But I suspect that in the future, where that's more likely to come from is better linkages to GP notes, and knowing that that you'd be able to follow through from there, because in some places that's done already.
Amazing, thank you very much. And
anything else that's there?
Yes, there's two questions in the Q&A box. So from someone who's anonymous has asked, as a paramedic, how can we best prepare an older NAF, which slightly relates to the question, but there might be more you'd be able to expand upon it. How can we best prepare an older trauma NOF or NAF prior to arriving at ED?
So I think the things that you want to be able to do as early as possible are adequate pain relief, and then depending on the general well-being of the patient, what we like to do as soon as possible is to start keeping the patient nourished and keeping their fluid going. So there's some places have standard operating procedures now, where if the patient is arriving later in the day, then unless there's some other medical reason not to feed them and let them drink, they can eat and drink straight away. Because it actually turns out that it's really unusual if somebody's booked into the department after midday that they get an operation on the same day. Whereas most places have a protocol that you starve them initially and then you have to get permission to feed, whereas it's probably better the other way around, that you start feeding and then there's very few that are going to go straight to theatre if it's later in the day. So SOPs where there's a time associated with that, and then you could perhaps give fluids pre-operative, pre-hospital as well. So pain relief and pre-hospital analgesia, sorry, pre-hospital fluids, I think are the probably important. Is there a place for delirium management? Yeah, too right there is. So it's a really informative presentation. Thank you. I read that bit because it sounds good. But is there a place for delirium management pathways in the management of neck of femur fractures and NAFs? I think the proportion who get or at risk of delirium is so high in this group that it should just be inherent in any of the pathways, which is one of the reasons for really wanting to move the patient from the emergency department through to an appropriate environment as soon as possible. Because if you do have delirium, then that's going to slow discharge and consume hospital beds. So there's a real incentive to avoid that. And ED is about the worst place for managing delirium. And I was talking to a colleague today where they have a system for dragging people, I mean, dragging as in taking their names rather than pulling them physically, but taking people from ED who have got this sort of problem to a 4-bedded area where they can keep them in an environment set for managing delirium as well as the other matters that they may have, because getting to the ward is an issue there, and they exchange patients then for those who are awaiting discharge on their orthopaedic wards. They do a swap with them. And so they keep the patients better placed, and it's so important in terms of hospital length of stay that it's something that we would hope that managers and trust boards will see. It's just as important to get these patients to the right place as it is to get a stroke to the right place, because you're affecting their outcome in a similar way and affecting their mortality as well.
Brilliant, thank you. And in the chat as well, someone's just asked, can I ask who you envisage taking the single point of contact role?
So, fortunately, somebody else wrote a nice bit about that. Hold on, what I'll do is I'll find that slide, because somebody wrote a nice. Let's get that one. So if I can share my slides again.
There you go.
Let's go. You got that?
Yes.
So the role of the single point of contact, the SPOC, sounds good. Sounds like something from Star Trek. In the pathway, there is a designated single point of contact with the following considerations. So they need to be senior, so they need to understand what's going on. Liaise directly with senior management. So the idea is that they should be in a position to police whether the pathway is generally multidisciplinary. And if they're not getting the backup, then they can go right to the top and argue it. And it could be performed by a ACP, AOUK, could be a doctor. The problem is that the resident doctors, the junior doctors, because they rotate, never really have the familiarity with the pathway that's there. And in most places with hip fracture admissions, those that are effectively doing this role are ACPs and AMPs who know it. And then there's a bunch of other things. That bit was written by a single point of contact, although it was a joint venture. That was written by orthogeriatricians, and single point of contact is a common concept in other areas as well.
Well, and then to expand upon that, do you feel that will be, so speciality wise, do you feel it will be ED based from an admitting speciality?
No, the point is that you don't. So you would go to the single point. If you were in ED, you would go to the single point of contact, and they would determine where the patient goes. Ideally, they're not solely affiliated to an admitting speciality, because otherwise that defeats the purpose of it. In some places, so in Bristol, they run pretty much a similar thing, because they just cohort the patients. They have all they run a geriatric trauma service, and so everyone goes under the same group. and that seems to function very well.
Wonderful. Thank you very much. So any more? People might be typing or not, but if not, I believe that is finished perfectly on time, actually, with some very detailed answers as well. Thank you very much, Bob. That was a great add-on to the presentation as well. And I think everyone's come away with a lot of, I always say food for thought. I'm not going to say food for thought, but hope almost that everything's going to be a little bit more streamlined and better in the future, especially for our older patients. So very, very much, I was going to say very, very much an informative meeting, a very informative evening. Thank you very much, Bob, for joining us and taking the time out. And thank you all of you as well, especially for sticking around whilst Zoom decided to play up. And I'm going to go make it sit in the corner after this. So thank you very much, everybody, for joining us this evening. Wherever you are around the country, many thanks for being here. Hopefully, and I know for a fact, looking at the names, I will be seeing some of you next week. So do come and find me. I will be the one that's running backwards and forwards, hobbling backwards and forwards, because I've torn my MCL. So hopefully I will see some of you next week. Bob, I will speak to you very, very soon. Thank you so much for joining us this evening. It's always a pleasure and never, ever a chore. So wherever you are in the world, take care of yourselves, take care of your loved ones. Thank you very much, and good night all.
Bye-bye.